Well, hello and welcome, everybody. I'm Dr. Greg Poland, professor of medicine and infectious diseases at the Mayo Clinic in Rochester, Minnesota. It's my privilege to talk with you very briefly today about COVID-19 vaccine updates and, in particular, variants. So, we're going to talk about the impact of viral variants on the effectiveness of COVID-19 vaccines. So, the variants of concern, as I'm sure all of you now know, have been given Greek letters. We have the Alpha variant from the UK, originally identified there, the Beta from South Africa, the Gamma from Brazil, the Iota from New York, Epsilon from California, and the uh, variant really surging now in the US is the so-called Delta variant, first identified in India. Well, these emerge, of course, because these are RNA viruses. SARS-CoV-2 is an RNA virus, has limited polymerase proofreading ability. And so the more times that you have infection go through a population, the greater and greater chance, by chance alone, that you will develop mutations that actually affect the spread or the phenotypic characteristics of these viruses. The other way, of course, that can happen, and a particularly dangerous one, is somebody co-infected with two different strains of SARS-CoV-2, and through recombination, exchange genetic material and make large leaps in phenotypic differences in the characteristics of that virus. So, what do we know about these? Well, we certainly know that the alpha virus, for example, the alpha strain was about 50% more transmissible than the original Wuhan strain. The Delta variant, about 50 to 60% more transmissible than the alpha variant was. As a result, at least one small study has shown viral titers or viral load as much as 1,000-fold higher, whether one was infected and had been unvaccinated or vaccinated. That's one study, and much more work needs to be done there. But the point is that so-called breakthrough infection can occur in people who have been vaccinated, primarily older people or people who are immunocompromised, and primarily asymptomatic or mild disease. That, of course, is not the case in people who have been unvaccinated. In fact, when we look at the unvaccinated in the US, they're about 3 times more likely to get infected than those who are vaccinated, 8 times more likely to have symptoms, and 25 times more likely to be hospitalized. Well, why are breakthrough infections occurring in immunized people? Well, number one, we have this ever changing and dynamic situation of variants that have the ability to attach to the human ACE2 receptor with greater and greater affinity, allowing for higher rates of infection and higher viral titers. Those can, as we said, be spread asymptomatically. And so you're starting to see drops in vaccine efficacy against symptomatic disease as we moved from the Wuhan virus to the Alpha strain to the now primarily prevalent Delta variant. What order of magnitude? Well, that's a little difficult to answer simply because it depends on age and medical condition. But in general, we're seeing about a 5-10% plus drop in efficacy against symptomatic disease when you move from alpha to delta variant. Well, how do non-pharmaceutical interventions affect the spread of these variants? They're very helpful. Surgical mask face coverings are not perfect. Even N95, given their name, are not perfect, but they are significant helps in decreasing spread of the variant. So the message needs to be at this point in time that you should not only get vaccinated, but you should wear a mask when you're outside your family bubble. What about travel is another question we often get. Well, this is a very difficult question because of people's differing risk tolerances. I think we shouldn't be doing widespread travel at this point in the middle of an epidemic with one of the most transmissible variants we've ever seen. And you don't know who you're on the plane with, depends on where you're going to and coming from. But suffice it to say that the more people that take it upon themselves to travel, the more continued spread we're going to have of the virus and the more continued sharing of different viral variants. So all of this together, I think, again, the message needs to be that we are developing variants that are starting to develop evasion mechanisms against these vaccines. We're starting to see slight drops in vaccine efficacy. As more people get vaccinated, the paradox is that you will see more infections in vaccinated people. That's the way it goes with every vaccine. As you have higher and higher levels of vaccination, the only place for infections to occur are in the vaccinated. And why does that occur? Because while these vaccines are extraordinarily good at disease blocking, like virtually all vaccines that we have in the US, they're not as good in infection blocking. And that's why we see the drops or the so-called breakthrough cases that we see. Most recent case was in Provincetown, Massachusetts, where you saw some 79% or so of the people that got infected were people who had been previously vaccinated. That doesn't mean the vaccines aren't good. It just means these were, for the most part, asymptomatic or mild infections. They didn't develop disease. But another reason, a motivating factor for vaccine and masking. Lastly, I'll mention a report released by a group of experts advising the British government, and they've put out very trustworthy materials. They believe that we will soon be on the verge of developing variants that may completely escape vaccine-induced immunity. This is an appalling state of affairs. If that were to be true, we would basically be starting over again. Hence the press, and you're seeing this here in the US of more and more healthcare organizations and businesses mandating vaccines because you simply cannot overcome all the ignorance and vaccine resistance by education alone. One of the interesting questions that comes up in all of this is, are vaccines themselves driving the development of variants? And the answer is both yes and no. In a sense, vaccines represent a mutational pressure on viral evolution. So when you immunize, let's say half a population like we have in the US, yes, you provide additional mutational pressure. At the same time, what you're preventing are deaths, illness, and surge demands on the medical system. So does this mean we shouldn't be using vaccines? Quite the opposite. It means that vaccines that are very good at blocking disease and less good at blocking infection, and again, that's true with all of our vaccines across the pathogens that we have vaccines for. It means we need to use vaccines at high levels. It's not the vaccine that's causing a mutation. It is anybody who gets infected, whether you're vaccinated or not, allowing for the development of further viral mutation. Again, it forms a motivation for a public health recommendation of being vaccinated and wearing masks when you're indoors or outdoors in crowded venues. I want to spend a little more time on this notion of the paradox of infections in vaccinated people, just to be sure I'm making the point clearly here. So let's just take the headline that everybody heard when the vaccine based against the original Wuhan strain came out. mRNA vaccines, 95% vaccine efficacy. Now that was against symptomatic disease. But if you look at those numbers in, let's say, the 60 and older age group, the 95% confidence intervals actually ran from 68% into the low 90s. So the real answer is somewhere in between there. Let's just take the most optimistic, that 90% of people who get the vaccine are protected against disease. That doesn't mean they're protected against infection. It's protection against disease. That means that some 10%, either because they're elderly, immunocompromised, or genetically predisposed to not respond to the vaccine, are going to be both infection and disease susceptible. There'll be another 10, 15, maybe with Delta variant, up to 20% of people who got vaccinated who are not going to be protected against infection, but will be protected against disease. That's what the observation has been. In fact, when you look in the US, 99.5% of the deaths are occurring in unvaccinated people. Some 97 to 98%, depends on where you look, people getting hospitalized are people unvaccinated. We will see that happening in vaccinated people because we can't completely block infection, and we can't expect that these vaccines are going to perform as well in a, say, 30 or 40-year-old healthy individual versus an elderly immunocompromised individual. I see and have heard from a lot of patients who, for a variety of autoimmune and other disorders, are of course on a very effective medications that nonetheless increase the chance that they won't respond well to a vaccine like a COVID vaccine. We've really seen this in our solid organ transplant patients, much lower levels of neutralizing antibody being formed after 2 doses, and a lot of talk occurring around the possibility of a 3rd booster dose for the immunocompromised for that reason. So again, this is why we are stressing a full series of vaccination and wearing a mask indoors and in outdoor crowded venues. Whether we will get to a booster dose and whether that will be the same vaccine or a variant specific vaccine is yet to be determined. As you know, ACIP, a committee of the CDC, did meet a couple of weeks ago to discuss this. No recommendation has come out yet. The only new recommendation is the masking recommendation you've all heard about in high and substantial transmission areas of the country. I think that personally is a little confusing, and the message needs to be, given the mixing of the population and the very dynamic change that you can see. Let's take Provincetown, Massachusetts, where they had next to no cases. And after 4th of July and all the parties, et cetera, within a few weeks, they had surged to over 170 cases per 100,000 population. So to me, the message needs to be, when you're indoors among people not your family, you're in a mask. When you're outdoors in a crowded venue, you're in a mask. And protect yourself and your community by being fully vaccinated. So that's a quick update on vaccine immunogenicity and variants of concern. So again, I hope this has been helpful. This is the first of a 6-episode series. We will do the next one on an update on case rates and epidemiology, followed by an episode on vaccine safety, an episode on pediatric indications, an episode on the important issue of equity and distribution, And finally, I will come back to do the 6th episode with my daughter, who's a mental health and trauma specialist, who's done quite a bit of research and writing on how we might best, as clinicians, handle misinformation and disinformation about the vaccines. How should we actually talk with the patient's family and people who stop us on the street asking questions about vaccines? So I hope you'll join us.